Thank you all for joining us for your lunch hour. This is a continuation of some work we started over a year ago. We really appreciate the support from our sponsor for this event, Boehringer Ingelheim team. But it's really about how do we continue to have that discussion about chronic kidney disease and start providing some examples and frankly a discussion about what works and what can we do to improve the care and for Washingtonians. Let's go to the next slide, Teresa. Just some housekeeping pieces. First off, we're going to mute everybody. There's a Q&A function, so if you put information in there like Sarah did earlier, we'll be able to try to run through those questions. Everyone who registers is going to get a copy of the slides and a copy of the recording. If we don't get to all the questions, we'll try to answer those in the interim and send those out as well. So you won't miss anything. You don't have to take notes, and we'll go ahead and get going here. The next slide is really our agenda. So this is me welcoming you. We have a couple of panelists that I think you'll really enjoy. Kerri Lenihan is really going to help show what they've done and what tools they put in place to be able to close some of the care gaps. Then we have Dr. Rael from the Aetna team, to sort of have that discussion from what can the health plans do. And we'll go ahead and get going. What I want to talk about is really sort of what we're seeing, from the Alliance and what we're seeing in Washington. So as you know, the Washington Health Alliance is a membership organization. We really do three sort of functions. One, we do public reporting through our community checkup. We bring people together to have those tough discussions, figure out how we're going to fix things, and then we try to drive the market. And this work today on chronic kidney disease really is, how do we start changing some of the clinical outcomes that are out there? How do we make sure people are getting the appropriate pharmacy management and treatment? How do we promote primary care? And then, how do we help people navigate the healthcare system? Next slide. If you're not part of the Alliance, we'd love you to join. We have lots of events like this one, but we also have committees where we can really dive into some of that information. So please get connected to us. You can go to our website, sign up for email, newsletters, etc. So you always stay informed. And the next slide is really, our job is really to help work together to improve care for Washingtonians. So with that, let me get into some of the issues related to kidney disease. And really, as we start thinking about chronic kidney disease, we start thinking about it from a system standpoint, but also a purchaser standpoint. And we're starting to put together a clinical dashboard of metrics associated with all the aspects of kidney disease, not just the diabetics, but beyond that. And next year, we will launch a collaborative process, primarily from a clinical standpoint, but we'll bring in other purchasers and health plans to really try to figure out how do we improve screening, diagnostic accuracy, treatment, and ultimately improve the outcomes. But let's get into a little bit of that. The next slide is really what the problem is. And the problem for adults is about 1 in 7 has a diagnosis of, or would have a diagnosis of chronic kidney disease. Diabetics are certainly more adversely affected, with over a third of that population. Most people are unaware. They're just not being diagnosed. And there's other high-risk people besides just diabetics, hypertensives, as you get older, history of cardiovascular disease, obesity, prior history of kidney injury, and smoking and tobacco use. So there's a lot of people at risk for kidney disease. So really the question is, how do we take all this data that might be out there and bring it to the clinicians so they can make a timely intervention? And I think that's where some of the gap is. It's just that information is not getting to folks at the right time. So we can improve screening, we can improve diagnosis, we can improve treatment, and then we can start reducing both the progression of disease, because we always want to do that, but also some of the other consequences, even people with CKD3 and 4 and cardiovascular events. Next slide. And this is what we're seeing in the Washington data, is that the screening rates are, we would say, not optimal. So only 45% of commercial population and only 34% of the Medicaid population. And this is with known diabetics who should be getting screened every year, pretty clear guidelines, and we're really missing on that. The next slide will show you the map of Washington. This is by counties. Green means you're above average, doesn't mean you're perfect. And when we look at medical groups across the state, what we're seeing is, you know, a very low number to a pretty decent number of 75% in one clinic. Now, our state average on the commercial side, 44%. Nationally, the 90th percentile is 58%. So we have a gap just in our average, but we have practices that are doing well. But how do we get everyone to do well? I think is part of that discussion today. Next slide. You know, some of it relates to, you know, the classification. We'll talk a little bit about that today. If you click one more time, you know, one of the issues is really some labs are reporting anything above 60 on a GFR as normal. So what the provider might see is normal, not that it was 61 or 62. And I think there's a big difference, we would all say, between someone who has a GFR of 61 versus, you know, 97. All of those are going to be considered normal. So there's a gap there in just the data that's getting sent to the providers. The next slide. Why do we do this? It's because as you move up the ladder in terms of your kidney disease, your risk for progression goes up as well. And really that's part of the issue, is how do we, you know, fully manage that population aggressively and early to help them not progress as well. Why is that important? Next slide. You know, you want to preserve kidney function, reduce comorbidities. You just want to manage that patient as actively as possible. The next slide really starts talking about the stages of kidney disease. You know, there are a lot of organizations out there, National Kidney Foundations, KDIGO, from an international standpoint. You know, stage 2, Diabetes Association, Heart Association are well informed with that. And then there's a lot of vendors that you start seeing out there, and this is a spattering of them, very focused on the later stage of CKD, usually late 3 or early 4, trying to prevent end-stage renal disease. But even those, the adherence and activation of those are sometimes limited. Next slide. And then when we look at the burden from a financial standpoint, you know, we always worry about those people who are on dialysis as costing a lot, but people before they're on dialysis are very expensive. And so many people are in stage 3 and 4. Those are the ones that we're trying to address. The next slide really gets us to, you know, an example from an employer standpoint, because we think about that a lot, and sort of 4 different types of employers. The first column is really, you know, your white collar, maybe it's a tech company, young population, but even that young population has a significant cost burden associated with people who have kidney disease. And in this population, we'd only estimate, you know, a couple hundred people, but even that couple hundred people will cost that company, you know, $4.5 million. And it gets worse as the population ages, as you have more chronic diseases associated with that. The next slide really looks at if you could reduce the progression of disease, what would the savings be? So it doesn't go to 0, but there is still significant savings from an employer standpoint. And the reason that employers should be, you know, pretty interested in how do we make a diagnosis quicker? How do we improve the care folks are receiving? Because where the costs are coming in is really early on in kidney disease, as well as later on. Next slide. And with that, I'm going to stop and let our speakers talk. And Kerri is from Mercy Health and has, a wealth of experience on what they've done within the practices there to start closing some of those gaps that we just talked about. And with that, I'm going to pass it on to Kerri. Thank you.
Thank you so much. Happy to be with you all today. I'll start with just a quick introduction here. My name is Kerri Lenihan, and I currently serve as the Executive Director of Clinical Care Integration at Mercy. And I'm personally based out of St. Louis. In this role, I support many of our various quality improvement and medical management initiatives within the primary care space, including our work related to CKD screening, evaluation, and management, and the corresponding implementation of all of the best practices and national guidelines in those respective areas of work. I am not a clinician by background, but work very closely with many of our clinical leaders at Mercy to help design and drive our various projects forward. So before I dive into the content that I've really prepared and outlined for today, I want to give just a little bit of background context to Mercy as an organization and the population that we serve. So Mercy's ministry spans 50 different hospitals and over 1,000 outpatient practices and clinics. We've got over 52,000 caregivers and close to 4,500 integrated providers who all contribute to providing care for almost 3 million lives annually. Geographically, we're spread across the Midwest, as you can see on the map that we've got up here, with sites of care across Missouri, Oklahoma, Arkansas, and then a small portion of Kansas. We also have outreach ministries in other states, including Texas, Louisiana, and Mississippi. We could go to the next slide. Okay. So prior to our deep dive CKD self-assessment that was initially prompted by our participation in the National Kidney Foundation's Learning Collaborative, we had quite a few tools developed to support screening for our populations that are most at risk for CKD, so hypertension and diabetes, and corresponding prompts for consideration of diagnosis when full evidence is noted within the patient medical record. However, we did not have as robust of tools in place to support confirmatory testing and ongoing evaluation and management for our patients who were already diagnosed with CKD. Our assessment also helped us to understand that ESRD and a more proactive transition to dialysis was also an area of opportunity for us, and that is one that we are still kind of digging into further and solutioning for in our future work. We could go to the next slide, please. Thank you. So our findings from our baseline assessment that I had referenced highlighted that our prevalence rate was below national average, which would indicate that we had a subset of patients within our population who have CKD but are currently undiagnosed. In regard to our screening efforts, our baseline assessment helped us to understand our current rates for our broader adult population and to understand how we compare to national averages, ultimately highlighting that our EGFR completion rate was slightly below the national average of 89.6% and above the national average of 21% for UACR testing. But given that benchmark is very low, we recognize that we've still got room to improve despite the fact that we're above that national benchmark there. Our data assessment also helped us to understand how many patients within our population have partial evidence of CKD, but have yet to have the corresponding follow-up testing to confirm or deny diagnosis. And then lastly, our review also helped to highlight that we have a small portion of patients that have full evidence of CKD, but are missing that diagnosis, which pointed out an opportunity to validate some of our existing tools and workflows. We could go to the next slide. So once we understood our areas of opportunity through that assessment, we deployed educational sessions for a handful of primary care offices as a designated pilot effort, again, kind of through that learning collaborative that I had referenced. And that spanned a total of 7 PCPs and their respective teams, using NKF's train the trainer approach and educational content that was focused on screening, confirmatory testing, diagnosis, and then treatment and corresponding management of CKD. So in addition to those monthly sessions that were focused on the topics that I had just referenced, we had those monthly sessions with the pilots, but in addition to that, we were working in parallel with our technology teams to develop and implement a few different EHR tools to support our CKD efforts as well, which I'll get into more in just the next couple of slides. Through our pilot effort, we saw improvements across the metrics that we had kind of identified and were tracking as part of this work. So we saw an 11% improvement in the patients with CKD who had a UACR completed in the past calendar year. We also saw improvements for both our hypertension and diabetes populations in regard to both the eGFR and UACR testing done within the past calendar year, with the biggest improvement being in those UACR rates for our patients with diabetes. We also saw an increase in patients without CKD, though who had a low eGFR, who were missing the corresponding UACR test. So we were getting more of those UACR tests completed for that patient population, which was great to see. 2 of the tools that we have developed and implemented actually went live after our most recent reporting window. So the majority of the improvement here, I think, can be attributed to our educational sessions and the direct work with our pilot clinics and digging into some of their individual data. So we're excited to continue tracking our progress in our next reporting window and kind of get a better understanding of the impact that our newer developed and implemented tools have made within this work as well. We could go to the next slide. So I know I prefaced to you all a little bit about the tools that we've developed and implemented to help guide this work for our primary care providers. So I'll spend the next couple of slides just providing a bit more information about those tools before wrapping it up with where we plan to head next within our broader CKD journey. So tools that we already had in place prior to our deeper dive into our CKD efforts. We had tools in place for prompting those annual screening tests, so the eGFR and UACR for patients in those 2 risk groups that I had referenced, so our patients with diabetes, our patients with hypertension. And we had also already had the initial framework and build for an ambulatory order set, what we call XCKD, that was in place, again, prior to this work. But kind of through our assessment and through the learning collaborative, we ended up developing tools that would help prompt that confirmatory testing for eligible patients, to prompt separately CKD evaluation for patients who are already diagnosed with chronic kidney disease, as well as some updates to that ambulatory order set as well to further enhance and optimize it. We could go to the next slide. Each of these just kind of speaks to those tools at a high level. So the first here is our confirmatory testing EHR alert. So the goal and intent of this tool is to appropriately identify those patients who have partial evidence of CKD and to kind of prompt and tee up for the clinician to order the clinically appropriate tests to ultimately confirm or deny that CKD diagnosis. And so that prompt helps to make the provider aware that that additional eGFR is needed to ultimately assess and determine whether that CKD diagnosis, to confirm or deny that, allows for prompting of the corresponding orders. And then just called out here that this is interactive with some of our other screening alerts with some smart logic so that we're avoiding duplicative order prompts for providers, and that we're certainly not intending to annoy anyone with multiple firings of a repeat ask. So have worked those in the background so that they'll be suppressed if a patient falls into another category that we've got a prompt for. This is specifically firing for our adult patients who, again, kind of meet that criteria of having the partial evidence of CKD, but no corresponding subsequent order that's been placed. So are needing that follow-up EGFR, and then have just noted our exclusions that we've carved out from this particular alert. We could go to the next slide. Fantastic. So this is an overview of our CKD evaluation prompt. And so the goal for this tool was to prompt our providers to consider the appropriate and recommended based on national guidance and evidence initial and annual tests and imaging for patients with diagnosed CKD, and to ultimately support the ongoing clinical management of that population. So the prompt helps to make the provider aware that this patient has CKD and is missing one or more of the indicated tests or labs. And we essentially match this to the national guidance that NKF has for annual and one-time at diagnosis testing and imaging, which is noted here. And then, as was similar in the EGFR prompt that we just spoke about on the previous slide, the prompt within our EHR helps to tee up the corresponding order based on what is still needed or missing for that patient. So it's dynamic. Again, population and scope here, our adult population. This is focused on those obviously with diagnosed CKD who are missing one or more of those indicated tests within our timeframe parameters. We could go to the next slide. The last one here is just referencing the ambulatory order set that was built out for CKD. The goal of this tool is to really help drive the appropriate clinical decision support, so evaluation, treatment, and referral if needed to nephrology or other specialists for our patients with CKD. Again, our adult population with diagnosed CKD is the group that is the intended population and scope for this particular tool. And in terms of the tool's overall functionality, it is a dynamic smart set that helps to pull in some of that patient level data alongside evidence-based guidelines and to ultimately help guide clinical decision-making for our providers. And then helps to kind of tee up that nuanced guidance for medications and labs based on the indicated staging for that patient. We could go to the next slide. Fantastic. So just wanted to close out with a couple of next steps. So what I spoke to you all about today is really what we've gone into and looked into and implemented so far in our CKD work. Recognize that we've still got other areas to explore and develop further within this space. So we plan to build off the education that was initially provided to our pilot PCPs and offer that to a broader set of our primary care providers, not necessarily in that one-on-one type of setting that we had with our pilot group. We've got a lot of PCPs at Mercy, and that would not be a scalable model. So really kind of opting into more of a lunch and learn type of session to allow for broader access to the educational opportunities that we had with our pilot group. As I referenced earlier, we plan to continue tracking the data points that we looked at in our baseline reporting assessment and those follow-up reporting windows, which will allow us to understand the impact of our more recently implemented tools, and understanding that impact will allow us to assess whether we still have opportunity for tool refinement or enhancement or just other opportunities to explore more broadly within the CKD space. And then finally, we plan to go deeper into our efforts related to guideline-directed medical therapy for our patients with CKD. And part of this will be expanding use of our ambulatory order set, which I spoke to, getting folks to engage in that tool and functionality, and in parallel, further developing a kind of clinical standard framework surrounding CKD to support this work and implementation within the primary care space. That is all I had teed up for our discussion today. So I'll turn it back over to our moderator.
Hey, thanks, Kerri. Now I have about a ton more questions for you, as some of the audience does as well. But we're bringing in Dr. Rael. And first I'll just ask if James, do you have any any comments, questions, or anything else you might want to add before I start peppering y'all with some questions?
Sure. Thank you. Thank you, Drew. I'm James Rael. I'm a medical director for the West Territories for Aetna, based in the Seattle area. And nationally, Aetna follows the National Kidney Foundation guidelines in regards to screening for CKD. And so, in terms of screening for patients at risk or with CKD, patients are screened with urine albumin and eGFR. Risk modification occurs in terms of the specifics in regards to the labs in the patient profile. Abnormal labs are flagged back to the provider in terms of if there are any abnormal values for CKD. And I can also talk on, but I'll stop there and wait for the questions. But there are a number of educational ventures that happen nationally. And again, in terms of medication management for early CKD, we do follow, again, the National Kidney Foundation guidelines for both the use with ACEs and ARBs as well as SGLT2s.
Fantastic. Well, Kerri, I think I'm going to start asking you questions. And you can see one in the chat, and I think it really gets to, you guys have done a bunch of work on CKD that doesn't tend to pop up as sort of top priorities for many health systems. And to do that and be able to integrate it with your EMR means someone has to devote some resources for you to do that. So there's a number of barriers that probably you had to overcome to get there. So how did you get your organization to one, jump in and say, yeah, that's really important, and then and maybe a little bit more on the EMR portion of that as well?
Yeah, and I was starting to type a response to that in the chat, but happy to answer it live. Honestly, it was the assessment, like doing the deep dive into our data and sharing the opportunity with our leadership team, both within primary care and more broadly, to demonstrate the opportunity that we had to better serve our at-risk patients, so those with diabetes and hypertension, as well as those with diagnosed CKD. So that really helped kind of set the stage for prioritization. I think our leaders were quick to say, yeah, we've got opportunity in this space. Also, general understanding that CKD is a large contributor to some of our unnecessary utilization and cost challenges, not just in a given health system, but across the nation. So there was support for getting into this work pretty quickly, and we are fortunate within the primary care team and at Mercy at large to have a really robust set of MTS, which is our technology service team, to help support our EMR work. But we did certainly have to prioritize this type of build over other things and make a trade-off there. But I think the data helped us to illustrate, hey, we've got some work to do for CKD. Let's get to it and see the impact that we can have by getting these tools in.
Well, it's fantastic having, sort of senior leadership helping to drive things, because that usually takes that to get you there. Sounds like you have primary care support, because you mentioned you would do a fair amount of education of the primary care docs. You're going to have to educate them on what the EMR prompts are going to show them. And so as long as they understand that, it's really what I mentioned earlier. How do we take a bunch of data that's out there and tee it up so the docs can actually, make a decision? And I think, you work on confirmatory testing is really important, because sometimes people miss that, or it's incomplete, and it looked like, you were, making 11-12% improvements every year on some of that, which was, fantastic. And is your EMR the Epic system? Is that what I remember hearing? And which is a really common one that we see here in the Northwest as well. So people shouldn't be too shy about saying, well, can't be done in my shop. Well, it can be done, and I think you've sort of explored that pretty well. Dr. Rael, one of the things I remember from working at Aetna, is that you had a really robust system in terms of being able to ingest lab result data, not just the claims piece, which is probably driving some of that ability for the plan to be able to identify care gap and be able to reach out to providers. And that's, I think that's highly valuable, and a number of our provider organizations have valued that system as well. Are there other interventions or solutions that Aetna has in place, maybe from an employer standpoint to address this, or is it really focused on the provider communication?
I think it's a little of both. I would say that, in terms of the from billing data, from coding data, we're able to pick up and send those results and have an idea of what those results are. But also there are a number of different groups within Aetna who are working on these particular issues. And so I've come across a number of physician leaders who are involved. There are a number of teams in terms of that also do education and such. Some of the teams are one team is referred to as the Healthy Outcomes Team or the HOT team. There's also a national Medicare program. There's also the HEDIS Performance Optimization Team. And in addition to those teams, there are other working groups that also work directly with providers, as well as, say, Bayer Pharmaceuticals, which performs webinars on an annual basis. And so there are a number of different entities that are attempting to address not only the issue at the early stage, but also at the chronic stage, which we're not discussing, but efforts for both.
One thing we all start getting talking and we sort of forget that there's a patient in there. So how do we engage the patient better, with these, care gaps that might get sent out by Aetna to a provider? Do they also get sent to the patient to say, hey, you might want to go talk to your provider about getting additional testing? And then Kerri, on your end, how do you better engage the member to start saying, hey, raise my hand, I forgot to do this test. You said you're going to do it 3 months ago, and I need to have it confirmed. So I'll open up for you guys to respond.
Yeah, I'm happy to speak from the health system perspective. I think we are on a variety of different fronts trying to think about how we better engage our patients in kind of their own health and decision making and advocacy for what they need to manage their chronic conditions. And we are working on implementing some updated education that would go out more as a after visit component. So that is still relying on the PCP or provider kind of helping to tee that up for the patient. But would love to see us, similar to what we've done for other chronic conditions like heart failure, have something that is more of a pre-visit component that goes out to the patient automatically, electronically through, your MyChart tool, for those that are on Epic, that helps to kind of give that patient some context to their condition and things to know, and maybe some things to follow up with your provider on at your next upcoming appointment, so that they're coming into that conversation more engaged, and ready to discuss some of those components with their providers. So nothing that we've implemented specifically for CKD, but I think would love to see that replicated for things that we've done for other chronic conditions.
I would also say that Aetna has a number of vendors that we contract with basically to address care gaps. And so a lot of these agencies are able to basically see the member at their home, evaluate exactly what may be missing in terms of a care gap. And if it is specifically something dealing with a screening for CKD, can address it at the time. These are also primarily based for a number of other chronic issues, but yet CKD falls right into what we would be looking for. And that's been going on a while, and we continue to expand. I want to say in the last year or so, we've been working with a group that primarily addresses issues with residents for the state of Washington, but that occurs on a national basis.
Fantastic. I think, Kerri, you guys probably fall into more of a best practice, standpoint. There's a number of practices that have been able to be, fairly successful. I think one of the questions that's in the among the group is, is there a way to share that best practice and what you've done? Is it something that's been either published in some way, or how are others who may want to learn more able to access your experience and what you're doing?
Yeah, we have not published this work, and that has been a conversation that we've had with NKF as part of their learning collaborative and a partner in that space. I think we would want to see, as I referenced, like our impact data. Now that our tools have gone live, we've seen some early access in that initial education that we've rolled out, but want to make sure we have a full picture of our like actual tool implementation and the impact there before we do something like publishing. But agree that the need for that, like sharing of best practices across organizations, is certainly helpful and beneficial, and something that we want to support and do.
Yeah, because you make it sound like it was really easy, but I'm sure it wasn't.
I know it always seems more simple in a couple slides than the actual work behind.
Yeah, we just did it and it happened. It's fantastic. One of the issues that you mentioned in there was related to managing blood pressure, managing diabetes, to target goals, and those are CPT2 codes. Does your EMR automatically just send those CPT2 codes to the insurer so that they can measure it, or to APCD so we can measure it? Or do you know how that works? Or you may not.
That's a fantastic question, and I will fully claim that that is out of my like day-to-day scope of work, and I'm sure there are other folks at Mercy who are much more aware than I am on that space. Happy to follow up on that though as a takeaway.
And then I think there's a follow-up question to my sort of pithy comment about how easy it must be, but the question is really, what are the first steps someone should be thinking about as they want to put a program like this together and get it up and running?
Yeah, I think one thing that's been really beneficial for us, and I'm saying us as myself and my clinical diet partner and our broader kind of primary care core group that helped to kind of initially champion this work, is having a means or a team that you can use and leverage for their insights and feedback and kind of buy-in and helping to champion that work. Within Mercy, and specifically within our primary care structure, we have a few different work groups that are comprised of physician leaders, APP leaders, our operations folks, and the one that I and my clinical diet partner co-lead is really focused on clinical care standards at Mercy. And so having that type of group that is able to give you really easy, direct feedback as you're kind of developing those tools and making tweaks to the criteria, that is super helpful. And so constructing that type of team, I think, is a super helpful piece of the work. And then also leveraging and setting the expectations with that group that they are going to help you champion the tools that you have co-developed and built. So we really rely on that team, especially the clinical leaders within that group, to help us champion the work and disseminate out to our frontline providers, where we know that the adoption is really key to get these things used to impact our patients.
Yeah. Hopefully that answered the person's question. I'm looking at that questions real quick, see if there's things that we haven't answered. So it sounds, just let me attempt to summarize a little bit. So it sounds like some of the keys to success was really having champions, keeping them informed, moving that along, and informing them as it went in terms of what their ask might be, going forward. So they don't just get to say, yeah, let's go do it, but they have to do some work on the way. And then, I think the fact that you're able to get results and be able to share that's pretty helpful as well, so people can see the progress that they're they're making. You know, from a big population health standpoint, we've seen some numbers in terms of, you know, the opportunity of identifying people with CKD, and then from a financial standpoint. So for every 100,000 commercial members, it's the added cost of folks with CKD is about $11 million. So you know, certainly it's a big number, but if you can impact, you know, 8% of that, you know, you really, you know, get pretty far. One of the questions that just popped in was, you know, related to that implementation piece. And did you get providers that were maybe pushing back a little bit, you know, or they weren't as compliant? And having run a physician practice, I ran into that all the time. They just didn't want to do what we were doing. And, you know, you had to take a different approach with them, or help them understand. How did you guys handle it at Mercy? Big organization, and you're doing a system-wide approach.
Yeah, I will say, not just for our CKD work, but more broadly, the work group that I just referenced, having our clinical leaders involved in that design process early on, I think helps us mitigate some challenges down the road, like having our, you know, folks who are also, they're in a leadership role, but they're also practicing still, and have a great sense of like what things are going to come up from their frontline providers in their given section or region. So we're able to triage and solve for those a little bit more upfront as opposed to reactively, which is obviously ideal. And there's always things on the back end that we get feedback on within our within the structure for these prompts that we've developed. There's a means of providers being able to give feedback directly through the EHR, which is fantastic and easy for them to be able to relay that. So we take a look at that feedback. If there seems to be confusion or maybe some frustration about like why this is firing for a given patient, it allows us to follow up with specific providers and either explain the why behind this tool if that maybe didn't get to them as clearly, or to help answer questions is that they may be missing in terms of the actual like function of the tool, or who it's intended to fire on, et cetera. So I think between both of those pieces, so having your clinician leaders involved upfront in the design, I think helps to mitigate some of the challenges on the back end. And then having a means for a feedback loop for providers to relay that, not having to like reach out to someone individually over email, I think helps to collect that, aggregate it, and follow up with folks in a more timely manner.
And do you do it, ever do like a recognition, or maybe not a shaming, we would never do that, but a recognition of those who are doing a really good job on either this initiative or other initiatives, where you can call out providers and say, you know, Dr. Smith, she's been doing a great job on whatever, and she's now achieved whatever percentile ranking or whatever. Okay.
Yeah, we certainly do that for a lot of our performance initiatives, and rely on our like section level physician and provider leadership to also help recognize the providers that, you know, they're directly supporting for their geographic region. Again, since Mercy is a big organization, we're across multiple states, we really rely and work closely with our regional leaders, both operationally and clinically, to help champion the work, to socialize the work, but also to call out those that are doing a great job and, you know, supporting these efforts as they're moving forward.
And then couple of questions popped in. So one is one that we've seen, which is, you know, people are getting, you know, they might get their electrolytes and creatinine done so you can calculate an eGFR, but what gets missed is sort of that UACR, and it sounds like you were able to get yours up about 11%, you know, from the over the course of the year increase. You know, how did, was it just the prompts, or was there something else that you might have done?
It was also a corresponding best practice that we had helped to educate to and kind of highlight within some of our EHR tools that fire for our rooming staff or for our providers, that really emphasizes trying to collect a urine sample while the patient is in the office. And that really helps to minimize the amount of times that patient is leaving and just forgets to go and do it, or that it gets maybe separated from blood work that they're completing and not done when they go in for follow-up at the lab, et cetera. So I think the more that we have focused on that workflow as the best practice for our clinics, that has proven to be really useful for our overall screening rates.
And another question more related to sort of the non-diabetics, I guess, is, you know, the HEDIS measure is all about diabetes, right? So it's, you know, do a kidney health evaluation for diabetes, but it looks like you added in, you know, some other things, right? So the hypertensive, the obesity patients, people with cardiovascular disease of some form, all those people being at risk. How do you decide which ones to do and how frequent to do them? And I'm going to be a little self-serving because we're going to build our own dashboard to measure those things. But how do you decide, you know, which ones and which ones to put an emphasis on?
Sure. And I'll be, well, maybe just take a step back. Those two screening tools were actually tools that we've had in place for quite a while at Mercy. So have to credit leaders before myself who were involved in this work to have made the decision to have not just the tool or prompt for our patients with diabetes, which is aligned more with our quality measures, as you had referenced, but to parallel that for our other risk groups, hypertension, cardiovascular disease risk, et cetera, because it's just clinical best practice, although it's not directly aligned with a measure. I think understanding that the downstream implications of not appropriately screening and then managing that patient population up front, I think was understood by many of our clinical leaders who help with the governance of our EHR tools and prompts, and, you know, the cost benefit analysis of, oh, another alert for providers to react to or close out of, versus we know that these patients are a big risk group for CKD, and we know CKD is a costly condition to manage. Like we need to move forward with having a parallel tool for those other risk groups, not just our patients with diabetes.
Good. Well, thanks for that. I'm not seeing any other questions in there, and I'll just leave it open for any other comments that you guys might want to make, or, you know, keys to success, or, you know, key learnings that you want people to take on with.
I'll just add that Aetna continues to build on teams in terms of the efforts to identify early recognition and treatment, and I think that that's important in terms of an organizational priority. It is a priority, and I only see it expanding in the future nationally in terms of recognition of this. And so I think that that's kind of an important thing, is obviously, as been said before, leadership understands that this is an important issue for many different reasons, let alone that we're really talking about improving the health of the patients who we serve. And so my hope is that, yeah, we continue to expand in terms of more standardized screening for other individuals who don't have diabetes, and standardize that in terms of frequency and such. But yeah, but I think that my goal is to understand that we will continue to, you know, be a leader in that regard from here and in the future.
Fantastic. Kerri, of course, there's another question that came in specific to you and specific to Epic, and whether, you know, the protocols and processes gets shared within the Epic user group, or how that might be used by other systems, or how they might get access to it.
Yeah, that's a great question. We have not, as of today, pursued sharing through like Epic Web, Epic user group, but can certainly chat with our Epic team about whether that's something that we can and should pursue. So happy to put that on my takeaway list.
Okay. And with that, I think we've answered the questions. I think we really went through a number of things. Kerri, thanks so much for the information that you provided from Mercy and sort of the challenges and the process that you went through, which is still ongoing, but you're getting a lot farther than some folks, and you've been able to leverage sort of the technology to be able to help providers in your organization make appropriate decisions, with data. So that part's fantastic. Dr. Rael, it's really good to hear what Aetna is doing from a comprehensive standpoint. The ability to mine your claims data to look for care gaps is really important, and the fact that you're able to push it out to folks doing care management and or directly to providers to be able to start closing those gaps are a way we can help that entire population. We recognize that EMRs are a great way to start teeing some of this stuff up, and so getting information and data in there in a way that's digestible versus a bunch of noise is really important. So Kerri, thanks in advance for asking your Epic team about what might be available for folks who have Epic, but I'm sure any other EMRs can start building some of that. And then we look forward to being able to report from a statewide level sort of the extent of screenings that are occurring both for the diabetics, but the non-diabetic population, the management of folks with a couple of chronic conditions, the use of medications, and then the prevalence over time and on how that changes. And we look forward, to our membership, really engaging next year from a clinical standpoint to kind of do what Kerri's done at Mercy and figuring out what barriers are within each individual organization that might, need to be overcome to be able to be as successful, as we're seeing in the Mercy population in terms of getting buy-in, getting senior leadership buy-in, and then really starting to make changes over time. So that's fantastic, and I think that'll help a population, and hopefully what we see at the end of that is that people, one, get diagnosed more, two, get treated more, but we start seeing a reduction in the big outcome, which is cardiovascular disease, and start seeing those numbers start dropping within that population as well. So thank you both for your time and your efforts, and appreciate it. And we'll give people back about 5 minutes of time so that they can get to their next meeting. But thank you all.
Thank you all. I appreciate that.
Thanks, James.
Thank you, Drew. So I will let you get back for your next meeting, but appreciate your time. Thanks as always.